You guys, some of you have met Jillian from my office, who's our medical assistant, soon to be nurse, and the new practice is going to be Pacific Diabetes and Weight Loss Surgery, and hopefully going to be here on the second floor for most patients, especially with the third floor getting spine. I think you guys are going to be getting most of the patients who come through the hospital for weight loss surgery, and we definitely want to make sure that you're up to speed in terms of feeling comfortable, or at least more comfortable taking care of these folks. And the first thing I want to do today is just make sure that you're not overly intimidated, that these are the same as most surgical patients. I mean, our priorities are the same for the most part. There are a few differences, but what a lot of administrators end up saying is, oh, what about the overhead lifts? Or, we don't use overhead lifts for the most part. Unless the patient's paralyzed, most weight loss surgery patients are up and walking within 2 hours of coming out of the OR, and they're certainly, even if they have bad knees and they have a walker, we're going to get them upright and ambulating with the same priorities as if we took their colon out or their gallbladder out. So this is not extreme surgery. It's not big medicine necessarily. These are not usually even the biggest patients in the hospital on a given day. Most people we operate on will be in the 200 to 350 pound range. People certainly can go up to 400 or 500 pounds, but that's more rare than you would think. The most important thing, I think, for us in terms of getting to North sort of ready is as much the team building as anything. You guys feeling empowered to call me and ask questions. The way that weight loss surgery patients have problems is when communication fails. If you have a bad feeling about something, you need to be, empowered to call, not to wait for more signs, because especially in these extremes, when people have more metabolic problems, just like the older patients, just like the younger patients, they don't often show big signs at first. A lot of times things are very subtle right up until the point somebody crashes. And if you look back, the subtle signs are there, and that's where you have to be, again, empowered to really say, this is just not right. This patient, yeah, people go for a walk and they get a little tacky up to 110, 120, but you get them back to bed and they settle down and they're in the 90s pretty quick, right? If you get somebody, after surgery who's tacking along at 110 and doesn't come down and things just don't look right, you don't have to wait for more evidence to call, okay? So I really, that teamwork and that trust for you guys to feel like you can call is probably the most important thing. And call, direct to my cell phone. That's my pager. That's probably if we could almost end it there in terms of just saying we gotta be aware of early subtle signs, and I'll go into that a little bit more later here. I also do want to talk at the beginning about this, because one of the other occasional tricks of introducing especially weight loss surgery to a hospital where it hasn't been done is a sensitivity issue. The patients are generally pretty attuned to the fact that society is bigoted against them. When I give the talk to docs, I always say, society's bigoted. Jay Leno can tell a fat joke every night where he couldn't tell a racial joke or a gender joke or a religious joke. He'd be off the air tomorrow. He can tell a fat joke every night. Well, doctors are more bigoted than most of society, and surgeons are the most bigoted doctors of all. And I always get a laugh out of that. But it really is true in medicine that there is a medical bigotry that goes around a little bit, and I think we just have to be particularly attuned that even in the parking lot on the way home, or even at the mall, people recognize you, people know who you are. You really can't afford to be snarky ever, and that's not true just about weight loss surgery patients, but it is particularly true. They are more attuned. One comment can wreck the whole
program.
Yeah, really can. So just be careful with that. And I mean, we all have patients that are sometimes irritable or irritating, and you don't have to love everybody, and we don't have, we have conflict, and we can have that, but just be aware that fundamental respect is got to be a 24/7 deal. And I always like to say that a hospital is just a hotel without nursing. It's just, you know what I mean? It's just a building. We can deliver. I think there's two things that we do in modern medicine. First is the old medicine from 1,000 years ago, which is just caring, right? Just being there, holding the patient's hand, whether it's your relative or somebody you're paid to take care of. Being there is a lot of what we do in medicine that doesn't take big degrees, but that caring part of giving care is really important. And if that's not there, we can be hyper professional, but if we're missing that core, that comes through as well. Some days that's all you can do, but some days, some days we have our own priorities in life and we're distracted. But just remember how important that is. Now, most of the rest of this talk is about the technical part of the care, but I'll tell you, the reason people are going to love you is because of the personal connection, and these are the happiest people in the hospital for the most part. And I always tell the other surgeons, my patients are all happy to be here. Yours are all bummed, because they're all sick. My patients are as healthy as they've been usually in a couple of years because we've gotten them ready for surgery, and then they're here to change their lives. And they've been waiting. They've been working at it to get to this point. So they're actually pretty psyched. Doesn't mean that they're not anxious as all heck. And anxiety comes through sometimes, and I know that people take it out on nurses. You know what I mean? I know that I've seen plenty of patients be sweet to me, and then, I hear 5 minutes later, how that goes. So I'm not fooled necessarily that you guys. I'm sorry.
They'll do little jabs.
Yeah, exactly. So I know you guys bear the brunt of a lot of the anxiety that people have, but remember that it is anxious, and especially a lot of these folks have a lot of pressure from families too. Their families freaking out. They're getting an elective operation, and they misperceive it as more risky than it is. And I'm not giving my whole hour-long talk today, so I'm just gonna we'll get to that a little bit. But in terms of the safety, weight loss surgery, gastric bypass these days, the mortality risk is now about 3 in 1,000. That is about the risk of laparoscopic cholecystectomy. It's less than the risk of a hip or a knee replacement. So when people talk about risky, drastic surgery, you can confidently say to them, hey, there's not an operation that we do that's not risky and drastic if it's on somebody you love or on you. But this is not, it's not the way people perceive that it was of, some major mortality risk. But even a minor mortality risk, when they happen, it's a drama. And we do have some pretty sick folks. All right. Just getting back one last thing on the sensitivity issue, just that whole disease model. A lot of patients still come in with that, having a hard time separating out where responsibility ends and shame and blame start. Shame and blame is not functional. It doesn't help you. Yes, we have to take responsibility, with any disease we have. We have to show up for our doctor's appointment. I always point to glasses, because your glasses don't put themselves on your face in the morning. If they need updating a couple of years later, they don't get you to the ophthalmologist. You got to go. You got to interact with the tool. You have to keep your glasses clean. The tool for surgery is very much that way for these patients, and they get very intimidated sometimes that it's not going to work for them. And you can really help reinforce that. Now, you guys will see that a year or two from now when we've done, a couple hundred operations. You'll be able to tell patients, I know you're going to go out there and just do what you're supposed to do, and it will be okay. You can reassure folks that the tools are effective, but they definitely have to meet the tool halfway, and that's where that responsibility does come in. Everybody worries about people being hyper irresponsible. There are really almost no patients who are that kind of flagrant irresponsible. People do want to live better. They just don't trust, that their appetite is controllable, and so they're worried about that. All right, so let's briefly go over the operations here. So you've got them on your little cards there too, and I've got my little handy dandy model here of a stomach. It's a little bit beat up. It's old. They don't make this model anymore, but it's nice in 3D, especially to see what a gastric bypass really kind of looks like. So if you imagine here, this is esophagus coming down to the top of the stomach, and this is continuous before we do gastric bypass surgery. The body of the stomach, the pylorus, the duodenum going down to the small bowel, which goes downstream, right? So what we do in gastric bypass, and this is the gold standard operation still, we take, I'll show you a stapler in a minute, but we divide the stomach so that there's just an egg-shaped piece or an egg-sized piece of stomach left up above connected to the esophagus. The rest of the stomach is divided away. It's not removed, but this is now a dead-end pouch. So we go down below, about 100 centimeters to 150 centimeters below the ligament of Treitz, so in the jejunum, and we divide the small bowel with a stapler. And if you imagine this is sort of like one of your Home Depot things, you know, tab A and tab B, you know, we divide it off, and tab B is now going to come up and plug into that stomach, okay? And then we count down about 150 centimeters here to point C, and we hook the A into point C, so now food goes down and joins all the digestive juices that are coming out of the stomach and the liver and the pancreas. So this food doesn't really have any digestive juice to be digested, and these digestive juices don't have any food to mix with, so digestion doesn't really happen much until you get down to where C is plugged in. That's the Y, Roux and Y gastric bypass, and this is called the Roux limb. And this is where you'll see most docs get very confused about what's the alimentary limb or the Roux limb and what's the biliopancreatic limb. This biliopancreatic limb carries bile and pancreatic juice. It doesn't carry food. Alimentary carries food but not digestive juice. And then the common channel is down below, has everything, the lower part of the Y has everything mixing together.
And that's the Roux limb?
This is the Roux limb, the upper part,
okay.
yeah. And I said 150. This is about the biliopancreatic limb is usually about 70 centimeters long, 50 to, well, it depends on who makes it, 30 to 75. So you can see that's pretty complicated plumbing, but it's not that complicated. And if you come into the OR and watch a couple of operations over time, and we'll have a poster in there for students who come through, and you realize what we're basically doing is dividing, and reattaching. That's the operation. It seems very mysterious, but it works very well when food doesn't go through here anymore. The diabetes gets better almost immediately. One of the important things for you guys as sort of intermediaries with a hospitalist being consultants sometimes, or a new hospitalist comes on and they're like, well, this patient was on 105 of insulin a day. Let's put them, you know, they're NPO, but we'll put them on 50. Most patients need 15 if they need anything. You know, it's a low sliding scale. Within 36 hours, their insulin requirements are way down, and certainly within a couple of weeks they go down very quickly, so you can't just send them home on their fixed Lantus doses. Before weight loss, people have hormonal differences in the way their insulin works. Now, with weight loss, people also get diabetes benefit. But so that's gastric bypass. I'm getting off into the other subjects. So what a sleeve gastrectomy is, and I put that second just because it's sort of in between. The second most common operation right now is a lap band, which we'll get to third. But a sleeve gastrectomy, basically, we start down here near the pylorus, and we divide this stomach. Basically, we turn a football-shaped stomach into a banana-shaped stomach. So we remove about 75% of the stomach, and leave a tubular stomach. We don't do anything with small bowel at all, okay? And food now just goes through this narrow stomach and down into the small bowel and out. If you eat too fast with ice cream, you've heard of dumping that you can get with a gastric bypass. You can get dumping with a sleeve. I'm a sleeve patient. That's what I had a couple of years ago. One of the cool advantages of a sleeve with that tube is if I fail my operation or my operation fails me, it's not that hard to go back and turn it into a bypass. You know, just go back and turn that banana now, you know, cut it off and you're ready to do the bypass. As opposed to a band where the band, and so this is a lap band. I'll pass it around here in a minute. This is the silastic ring. It goes in through a 15 millimeter laparoscopic port. I'll show you ports here too. This is as much show and tell as anything. So these are laparoscopic ports that we put in. You guys have seen gallbladder patients and stuff. So we put it in. It's kind of a lightly cutting thing. We have to cut the skin, but then we go through the muscle with these ports, and then this comes out, and our instruments can go through there. So this is a 5 millimeter port. And this is a 12 millimeter port. We actually, for lap bands, we have to have a 15 millimeter port, a little bigger port to get this through. But I'm not going to take it all the way apart. This is not on there at first. We assemble that later. And we just push the tubing in and pull the band in behind, and once it's in the abdomen, we circle it behind the stomach and pass it through the buccal and close it down. And that lap band then